people. How are you doing? Welcome to the Sports Therapy Association podcast, recorded live on Tuesday nights on the Sports Therapy Association YouTube channel. I'm sorry to keep you waiting. Apologies, I am 3 minutes late. We're having a few technical difficulties, but we're here now. And if you are listening to the podcast, then this is recorded live. And the advantage to that is people can come in and ask our wonderful guests questions directly. And if you do come in, then I can bring your question up on the screen. For example, Glenn Murphy is here. Glenn Murphy, if you're joining us live now, you can see there's Glenn's wonderful stoic presence there in photo form up on the screen with a good evening, everybody's. Gary Benson is in the house, founder of the STA, Sports Therapy Association. Hey, Gary, how you doing? Nikki Mansfield is here saying, oof, only just remembered to tune in. Still got here before Matt. Yeah. Thanks, Nikki, for rubbing that one in. And Isabel Hodgkiss, how you doing, Isabel? Thanks for joining us. Hi, everyone. My first time seeing this live. Very excited. Pressure is on. Pressure's not on me. I'm always the same, but pressure is definitely on my fantastic guest. Not at all, because I'm so excited about tonight's episode. We're going to be talking to Dr. Sarah Rollins, who is a fantastic person to talk to about buttock pain and indeed everything hips. A magnificent past, too. I'm so excited for Sarah to tell you about in person. Wonderful experience and all sorts of things. So before I do bring Sarah Rollins up in person, just a thanks to last week's guest, Holly Soper-Doyle. Holly was here talking about hip dysplasia. It was a really good episode, and thank you for everybody who has sent emails in and thanked us, because it is an area once again which has terrible lack of awareness, a lot of misinformation, and once again an area where people potentially who need to see the right therapist to be diagnosed properly, they may well come through our doors first of all. With pain, with hip flexor pain. It's never about the hip flexor, as Holly said last week. But yeah, they may come with hip flexor pain. They may come with adductor pain. They may come with pains which could be masquerading. And we think, right, we're going to stretch that hip flexor out. We're going to massage here. We're going to prod here. We're going to give you exercises here. And we're not doing the subjective. It was so wonderful. And I got an email saying this, that the email actually said, there's a bit of a pattern here with your podcast, isn't there, Matt? Your guests are really homing in on the subjective, and that's what it's all about. If you start twisting and prodding and pulling somebody and you haven't even asked whether they've got any family history of blah, 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 or asking about flexibility was another one, party tricks. We heard this with hypermobility. Ask the person if they're famous for doing any party tricks or anything like that, because normally that's a giveaway sign that they have been doing that. And it could be a link towards hypermobility and the other things associated with that. So wonderful episode. It was really nice to sit back and listen to Holly Soper-Doyle educating us. Obviously, it's available on all podcast apps. And if you want to watch the video, then it's there waiting for you on YouTube, and also at thesta.co.uk. There we go. We are continuing our focus on the hip tonight. Like I say, Dr. Sarah Rollins is going to be here talking about buttock pain. So not too much of a subject there. Huge topic, but we are actually dividing it into two parts. And I'm happy to say that next week, I believe Sarah Rollins is coming back again. And with her is going to be Emer, not Emma. No one call her Emma. Okay, you've heard it here now. I'm warning you. It's going to be sports physio, pretty sure. Yep, sports physio. Emma, I'm just checking. I think it was Acton. Let me get this right, please. Yes, Emer Acton. Emer Acton. It's going to be such a Freudian Homer Simpson slip now. Emer Acton's going to be joining us, looking at the practical side of what to do if you've been given the correct diagnosis. Maybe if you've referred someone on and it comes back, or if you're a sports therapist and you're allowed to diagnose, then we're looking at the practical things to do with this person, rather than just letting them slip, getting undiagnosed or being the wrong stuff, or maybe even being scanned and led down the road, which they really don't need to go down. So yeah, double show for buttock pain. Really excited about that. So that's it. Right. Just checking here. Everybody's happy. Everyone can hear me okay? I want to make sure that's happening. Everyone comfortable in the live lounge? Good. Marco Mendoza, that's it, isn't it? The same as Mendoza, is here. Good evening to you. Right, so without further ado, what I'm going to do, sit back, enjoy yourselves. Feel free to ask questions if you have joined us live, and I shall bring up Dr. Sarah Rollins. There we go. Right, let's see if this works, Dr. Sarah Rollins. Can you see yourself on YouTube?
I can see me. No, I can't on YouTube.
Oh, can you not?
Oh, no, I can now.
You can now. Yeah, it was just cutting in. Right, so we had a bit of a technical difficulty with me. I'm going to accept all the blame here. So you're seeing yourself on YouTube. You're hearing me on your computer. I can see you. Everybody else can see you. Perfect. So we're going to kind of work this out. I think it's going to be okay. Thanks for joining us.
No problem.
Where are you, out of interest? Where are you based?
Where am I?
Yeah.
In the world. So I work not far from Guildford. So one direction, I work in Aldershot for the MOD at a rehab centre, and I work in pure sports medicine at Rains Park, which is not far from Epsom.
Oh, fantastic. I know Epsom very well. I used to go out with a certain daughter of the headmaster there. So, yeah, I used to walk around Epsom quite a lot. Yes, lovely place. All right, so I'm down in Brighton, so we're not too, near Brighton, so we're not too far away at all. Fantastic. Well, thanks for joining us. I wanted to start off by saying that, I mean, all of my guests, the wonderful people they are, have got fantastic history and CVs and experiences, but yours kind of shone out once again. I'm like, wow, here's another CV. You've got so much going on. You mentioned Ministry of Defence there, where you work as well as pure sports medicine. If I remember rightly, about 11 years, has it you've been involved in the army?
Well,
you were there in the army for 11 years. We've got to go back a little bit now. We're going to take it back. You tell me, how did that all start?
So, I mean, I joined the OTC when I was still a medical student. So I have been involved with the MOD since I was about 19 years old, which is obviously not very long ago.
Exactly. I was going to say 4 years.
Yeah, exactly. However, in that 3 or 4 years, I've managed to squeeze in a 10-year army career alongside my medical training, and also 10 years, or is it 11 years 11 years this January at the Regional Rehab Unit in Aldershot, which is, so the way that the MOD rehabilitation system is set up is that everybody's heard of Headley Court. Well, Headley Court's now closed, and there is now a new place called Stanford Hall, the Defence Medical Rehabilitation Centre. But that's a kind of tertiary centre, referral centre. And so around the country, we've got 12 regional rehabilitation units, which is essentially a gym with rehab instructors, physios, rehab physios, and then I run a medical clinic where we do diagnostics, injections, ultrasound, that kind of thing. So we're kind of a secondary care centre, and Stanford Hall is the tertiary centre. Wow,
amazing. So, and you mentioned ultrasound just there, and you're very much involved in ultrasound, aren't you? You wrote the FSEM UK training guidelines, and that's all used now, isn't it, for training and mentoring?
So they did have some, yeah. And
you updated them.
You know, to be fair, they were based on the Royal College of Radiology guidelines, but there was a need to kind of build some guidelines so that people who are not radiologists, who work in sports and exercise medicine, had some, training. So some clearer training guidelines that are a bit more like adult education, where you do training and then demonstrate competence, and you demonstrate that you're keeping your competence by annual appraisal and ongoing learning. And that's so it includes the syllabus, but also includes recommendations on numbers of cases and logging and things like that. So yeah.
Okay, marvellous. And before we get onto the topic of buttock pain, which I know we'll talk about, it's such a huge subject, I'm sorry to kind of throw that into your lap. But we should also mention as well that you're pretty active as a runner, aren't you?
Oh, yes. So my main sport is orienteering, which is a running sport. It sometimes surprises people because they have an experience at school where they get given a map and it's very wet and rainy and muddy, and they get dragged around the bit of countryside. But real orienteering is like cross-country running, but you just don't have a marked route, so you have to work out your own route. Mm-hmm. So I was staggering around in the New Forest on Sunday in the ice, which was both fantastic, but also, a bit chilly.
And I'm going to have to squeeze it out, obviously, because as with all my guests, you're so modest, but represented Great Britain, 11 World Orienteering Championships.
Yeah,
that's still correct.
I've been very lucky to represent Great Britain 11 times at the World Champs, with a few World Cups thrown in as well. I mean, I retired. actually, I can't remember how many years. I think I was about 10 years ago now, perhaps. But I still participate as a master, and I go to the World Masters most years, and was lucky to win a gold medal last year. So, yeah, it's brilliant.
It was lucky. Yeah, it was luck that got you, was it?
Wonderful bits of forest. Yeah.
I've worked with a few orienteering athletes in my time, and they're fantastic creatures. I mean, especially when you're looking at the distances and the tales I get of, oh yeah, always hallucinating, and you just have to ignore it and crack on with it. And I always remember people who were trying to get past that 100 miles were kind of, there was a couple
I think you're talking about ultra running. So
ultra running, but orienteering with maps and things as well.
Okay,
so they're going across.
So most orienteering is not quite so far. Most orienteering is up to about, well, it depends what class you're in, but it could be up to 10K, 11K, something like that. And so it's more like a cross-country race.
Right, okay.
But yes, I mean, obviously people do things like the original mountain marathon, the OM, and things like that. And I guess that's still orienteering, but that's kind of like mountain orienteering. Yeah.
I've heard tales of where like the winner takes the person at the front takes the wrong direction, and the whole of the rest of the pack just following them, thinking, well, that's the way to go. And then, and I've worked with a few athletes who still managed to win, but they led the whole of the rest of the pack the wrong way, because it's just crazy trying to find your way around out there. But yeah, amazing athletes. I salute you all. I could never do that. I can't even get to Brighton from Lancing safely if I'm driving. I've got ridiculous orientation. It's a joke. Yeah, and a gold medal last year as well, 2022. So definitely very much involved still. So yeah, amazing. Right then, buttock pain. Very big topic, isn't it? You've mentioned a few times to me now. We'll do what we can because it's huge, isn't it? There's an awful lot can be going on.
Yes, there's a lot of anatomy. To me, some of it's a bit complicated. I would say that it's probably an area that scares doctors and physios, and it scares everyone a little bit. Once you start learning what's the possible cause, it all gets a little bit too much. So hopefully we'll be able to simplify it though, and kind of because it doesn't have to be complicated, and you can, it's just about recognizing when perhaps somebody might need to be referred on, and what you could be doing in the meantime. So I think a good place is to start is just defining what we mean by the buttock anyway. So should we get started?
I think so. I'm just pleased you've already done a great thing by saying it is complex, because having taught the syllabi for level 3 and level 4 sports massage therapy, a lot of therapists fresh off the block love it when someone comes with buttock pain, because it's kind of the area that's concentrated most on, because it gives people a chance to practice their soft tissue release on the piriformis and dig elbows in, and it's kind of welcomed, and people are generally excited if they want to demonstrate something. Oh, can I do the buttocks? Can I do the buttocks? So I'm hoping that people listening are already thinking, wow, I thought that was just a biggest muscle in the body, and someone to get your elbow in, and it was pretty obvious what was going on. But the fact you said it is complicated and it could be quite a lot of stuff going on has opened a door, I'm hoping, in a lot of people's ears. So yeah, looking forward to it. So, well, I mentioned piriformis. How often, I mean, I can't say how often is it the piriformis, but do you see that a lot of people do jump in thinking it's something to do with piriformis too much of the time?
Yes, I would say yes, that can be the case. So if you want some figures, so obviously having done a bit of background reading, I don't generally do figures because I forget them, and also they don't actually necessarily help the patient. But apparently 6 to 36% of people that turn up with buttock pain or pain in their leg and their buttock have piriformis syndrome. It could be 6%, it could be a third of the you see. So I guess it depends which literature you go to, but the piriformis syndrome, or at least pain that is related to the sciatic nerve that is not caused by the lumbar spine, but perhaps caused by muscular spasm or overload, which people could call piriformis syndrome, is definitely a thing. And what we mustn't do is, get cross with each other, or cross with our patients for trying to make sense of what's going on. And actually, people come in saying, I've got sciatic pain, and that's absolutely, I understand exactly what they mean by that. And sometimes it is piriformis syndrome. So, but it's just understanding what that means, what you can do to help, and when it might not be that.
That's such good advice, because that looks at the other side, where if you are a little bit more evidence informed or evidence, and you've listened to this podcast, then just because you get a patient coming in saying, oh yeah, I've got sciatica pain or I've got piriformis syndrome, then yeah, it's important not to just dismiss it and say, oh no, the last person you saw, do you know, everybody says that. It's not actually that at all, because it's not professionally going to do you any favors. Patients don't like to hear about bickering and competing amongst therapists, do they? So I like the fact you say that yeah, if they think it's, the sciatic nerve and that's the cause of it, then there's no need to deny that. You can go use their language. It's interesting. I give it as well because it's just interesting. I think when you're looking at the anatomy, but I think it's very low. I think it's about 17%. And we teach this because it's just a bit of interesting anatomy, where the sciatic nerve actually pierces the muscle. It's something where eyes light up and people go, "Ooh, that's interesting." And you can normally find a video or something from it. Is that something in your experience you see where that is the cause of it?
Yeah. No. So first thing to say is that this is the Beeson and Anson classification of the different anatomy of the sciatic nerve related to piriformis. And I always think with these things is the patient didn't have any pain, and they've had that anatomy all their life, and now they have some anatomy, or was it something that happened it might have perhaps put them at risk. But they've also done studies on cadavers where they've seen people who've got sciatic nerves gone through the piriformis, round the piriformis, part through, part above, part below, and they had no symptoms at all. So we can't say it's definitely anatomy. And then when people do get symptoms and they happen to have altered anatomy, we can't say it's definitely anatomy. And I think we're just getting our knickers in a twist about something that's quite fancy. It's the sort of thing that humans love to latch onto to say, oh, I've got a sciatic nerve that's it's probably going through my piriformis. That's the reason why I have all these problems. But actually, if we just think about doing the simple things, trying to restore good movement, trying to gait re-educate, trying to improve range of movement, all these kind of things that hopefully we'll talk about next week. If we just do those well, then people can be restored to not having pain, yet they've still got the same anatomy. We don't go around chopping people's sciatic nerves free of the piriformis for the most part. So,
great point. Yeah, and again, Sally, it does happen. We do get excited by the idea of something that's abnormal or slightly different, and then patients could easily start blaming that for the pain and just think that's it. I can't do anything about this, and then I'll look at other strategies. Yeah, very interesting. So, okay then. Do we stick with piriformis syndrome, or do we start talking about other things it could be, or things which you feel are missed out?
Well, I think a good place to start might be just to define what we mean by the buttock.
Okay.
It's basically anything above the gluteal fold, so the crease of your bum at the bottom. And then it goes up to the greater trochanter, which is your femur, the bit that sticks out at the side. And then it goes up to your anterior superior iliac spine, which is the little knobbly bit at the front of your pelvis. And then it goes back along your iliac crest, and then it goes to the midline. So basically anything between the midline, the anterior superior iliac spine, your bum crease, and your iliac crest, that's your buttock. And of course, you've got one on the other side. So if people come with buttock pain, very often they will have it on the one side. And I guess what we want to know is it caused by something on the inside of the buttock that's causing pain in the buttock? Is it caused by something outside the buttock that's causing pain in the buttock? Or is it something inside the buttock that's causing pain inside the buttock and outside the buttock? And that's basically your three options. And there are clues as to which it could be. And as a bit like a stuck record, a lot of those clues come in the subjective history. So I think it's worthwhile then exploring what is inside the bit that I've just defined. So we've got and in fact, before even that, perhaps thinking about what that area does. So the pelvis is this wonderful weight-bearing structure that is protective of what's going on inside the pelvis, and yet it also has to allow the passage of a fetus or a baby in the female anatomy, and it also has to have all the attachments for the trunk muscles and the leg muscles. So it's this kind of junctional zone between the bit above, the bit below, and the actual hip joint itself, as well as being this dynamic and have some slight rotation, and also allow, babies, and also pass urine, go to the toilet. All of those structures, it has to be both, structural and supportive, but also allow dynamic movement. So in order to do that, that's why it's complicated. And there's an awful lot of stuff in that area. And so if we're thinking about what is then in the buttock, we've got glute max, glute med, and glute min. They're quite nice and easy to remember. And they're attached around the kind of iliac crest. In fact, I have a pelvis that I can show you.
Just tapped out one here I made earlier.
So you've got your gluteal muscles that will attach here. So you've got your glute max, glute med, and glute min, and they will come down and they varyingly attach to the femur. Then we have other muscles that are deep to that. So our sort of deep posterior hip muscles, which include piriformis. And I'm going to come back and talk about the anatomy of piriformis in a minute, because it's reasonably interesting. Well, I think it's very interesting, but then I'm a bit odd sometimes. Then we have the 4 other deep posterior hip muscles, which are the gemelli, superior and inferior, with obturator internus in between, which also is an interesting muscle, which we can talk about. By the way, I'm an anatomy enthusiast.
Cheers.
And then we have quadratus femoris, which is the final posterior deep hip muscle. So there's all these things going on behind. And in between the two, we have this deep gluteal space or subgluteal space. And we've called it a space. It's not actually really a space. And if you look at it on ultrasound on an MRI scan, yes, there is an area that allows the passage of other stuff that isn't muscles. It's not a huge space. It's not like you go in there and there's room to move. It is full of vessels, it's full of nerves, and it's full of then a little bit of fatty tissue to protect those structures. But in that space, we have our sciatic nerve. We've got a variety of other nerves going to other little other muscles. We've got vessels, and as I say, we've got some fat. And it's that deep gluteal space where we might then get the compression of the sciatic nerve that might then give you your sciatic type symptoms, which we can come back to. Of course, then we've got the things that are slightly more outside the buttock region, which would be our hamstrings connecting to the bottom of the pelvis at our ischial tuberosity here. And the pelvis sits like this, so it doesn't sit like that, it sits like this. And so they attach at the ischial tuberosity down here. Then we've obviously got our sacroiliac joints at the back, one on each side, and then we've got our lumbar spine, which is also outside the buttock region. So the SIJs actually are within the buttock. So we've got our joints, we've got our muscles, we've got nerves, we've got vessels, and but we mustn't let them frighten us. If you are an anatomy enthusiast, it's not that difficult to go and look up what there is. And understanding their functions does help with diagnosis, and I do prefer to have an anatomical diagnosis. I know that there's various schools of thought where people are not necessarily as keen on having a mechanical cause for pain at all times, and absolutely there are reasons why people might have pain that include psychosocial factors, but nevertheless, particularly in the population I look after, either in sport or through the military, there often is a structural cause, because it might be in a traumatic injury or some kind of overload injury. And I like to be able to, even if it's not completely accurate, to be able to hang my diagnosis on something that makes sense in the clinical picture, having taken a history. So, because I think that gives both myself and gives the patient some context and some control that then allows them to go, right, that makes sense. I can see what I need to do. I can see what you're saying. And therefore I will engage with doing what I think would be helpful. And you're right. You mentioned about, talking in the patient's language. So I will try to, if they've used the word sciatica, I might, and absolutely, it is a word that describes pain that can start in the buttock and that often refers into the leg. I suppose the technical term would be kind of radicular pain, so pain related to a nerve. And that nerve doesn't have to be injured, it can just be irritated, causing pain that then refers into the glute or refers further down the leg. I've thought for a long time. Is there anything I've...
No, it's wonderful. It's really, really useful. I can sense people listening to the podcast ticking things off and answering the questions before you said them and testing their anatomy. So it's a great breakdown of what's going on underneath there. I'm interested in talking of pain. Often we try and kind of distinguish what's going on by the type of pain that someone's experiencing. So typically if you look up kind of sciatic pain and they talk about something that's going to be more sharp or burning, and if you're looking out for those words and the patient using those words, then that's supposed to help. How much does that help in your experience, or can the pain experience be different depending on the person?
Yeah, so people do use lots of different words for pain, and I think it is very subjective. So the patient will choose the words that mean the most to them. For me, it's about putting it in context of where the pain starts and where the pain goes often, and its associated features. Like if I've got pain that starts in my bum and it goes down my leg, and also I have pins and needles and numbness, I'm thinking, okay, this is a nerve. Yeah. But even that kind of referred pain, again, from the glute into the thigh, is going to be into the posterior thigh, is going to make me start using my sieve that says, okay, well, it's very likely to be one of these few things. It's very unlikely to be those things. And so, defining pain is really important. And this is part of the history, is one of the biggest things that certainly doctors get taught at medical school is, understanding where the pain is, and, what is it like? Where does it go? What makes it better? What makes it worse? How bad is it? There's some people so I always ask people how bad things are, and I ask them to give me a number out of 10. And there are some clinicians that prefer not to put a number on it. But I'm quite a sort of logical person. I like working in kind of, it helps me to understand the patient better, even if it's not just their pain, even if it's the psychological impact of their pain. I want to know if this pain means a 10 out of 10 for them. Even if I think, well, you don't look like you're in 10 out of 10 pain, doesn't matter. To them, it means it is bad because it affects their function, it affects their sleep. So I'm interested to know, is it 10 out of 10? Is it 1 out of 10? And I ask them, what is it when it's on a really bad day at its worst? What is your 10 out of 10 pain or 8 out of 10? And then I usually follow that up by, what causes 8 out of 10 pain for you? So I want to know what their, their significant aggravating factors are. And then also I want to know, well, what is it on a good day? Can you ever have no pain? And sometimes patients will go, sometimes I don't have much pain at all. And I'll go, no, do you ever have 0 out of 10? Nothing. And if it helps me to understand if they say, yes, I can be completely pain-free, compared to the person that goes, oh no, there's always something in the background. And then I like to know so I do spend a lot of time understanding what their pain means for them. And of course, then I want to know the associated features. I want to know where else it goes. Does it stay in your bottom? Does it go anywhere else? And I want to know, is it cyclical? Does it come on, for example, in women with their period? That might make me start thinking about, oh, actually, is this something else altogether? Related to, for example, menstruation or endometriosis or something like that. There's something not even in the buttock that I haven't even mentioned yet. And then, of course, I do want to check my red flag. So I want to make sure, thinking about night pain, rest pain, weight loss, night sweats, then I want to know about inflammatory causes. Do they have psoriasis? Do they have stiffness in the morning that lasts longer than 30 minutes? Do they have dry eyes, joint pains, changes in their fingernails? And people with inflammatory causes often I will say to them, do you wake up in the night and do you get up and walk around? So if you have inflammatory back pain or pain wherever it is, often they feel better when they move. So inflammatory pain often to your kind of your non-inflammatory back pain or sciatic type pain, where they're like, no, if I and I'll take some painkillers until it goes away. And a military rheumatologist always told me that if they get up in the night and walk around and start doing exercise, that's inflammatory pain. And obviously then also things like infection. So it is possible to have infections in the deep gluteal space and around the buttocks as well. So we're thinking about fevers, systemic, so body symptoms, and diarrhea, constipation, that kind of thing. Because there's so much, it's not just the outside of the pelvis, you've got a whole load of stuff going on inside the pelvis, and suddenly you're dealing with medical issues, and they're not so far away. So, and that's not to frighten people at all, and most people that will turn up wanting a sports massage won't have a medical problem, because human beings are sensible and generally won't take their change in bowel habit to somebody who wants to do soft tissue work. But these are important things to talk about, and I think that often you're in a very privileged position when you lay hands on someone, because often, and certainly, having spoken to my physio colleagues, because doctors don't generally do that kind of hands-on treatment. Yes, we examine, but we're not really treating patients, and it's in those moments when you do get an opportunity to actually lay your hand and actually see if you can genuinely make someone better by touching them. They will often tell you things that they perhaps wouldn't have told people, because there's a relationship there that you develop, and they will maybe open up to you about the other stuff that goes on. And there's that therapeutic value in that as well. So I think I've got slightly off track there, but I'm very enthusiastic about giving patients that opportunity to open up about the other things. That
Definitely. No, there's, again, I can imagine
so much worse. Yeah.
I can imagine people listening thinking, I've got to have at least another page here on my subjective on the medical questionnaire I give people, because you've mentioned things which just aren't taught on courses, unfortunately. And we had Jack March on rheumatology, physio. And again, he was talking about things where you've got to ask these questions, because once again, not diagnosed properly for maybe, I think it was sometimes up to 10 years. We had somebody talk about endometriosis and all sorts of things where they may well come to us because they're living a life where they're fed up. It's been going on maybe for 5 years. It's up and down, and they just think, I just want to lie down and just relax, and they'll come through the door. And sometimes it can be us if we ask the right question and we recognize that they've ticked it and have a little conversation. Then we just say, oh, I recommend that you go and see this person, and that might just cut that 5 years of no suitable help down and just help change that person's life. So I like to think that, soft tissue therapists should feel empowered by these sort of conversations.
Because there's nothing to be frightened of at all. It's all clinicians will, I'm going to say fail. I don't mean fail. Will forget to ask perhaps a key question every now and again. And that's why the power of coming back to things as well, and seeing them a second time and having thought things over, and they might tell you something else. Yeah.
Wonderful. Okay then. How about pain when sitting down? Because a lot of time that's kind of jumped out. Oh, it's taxi driver syndrome. Did you know Piriformis? Someone's called taxi driver syndrome, and suddenly you're telling this story and you've automatically assumed it's going to be Piriformis syndrome because they said it hurts when they sit down. Again, that could be a symptom associated with quite a few things, couldn't it?
Absolutely. So, I mean, one of the things that we sit on when we sit down, we sit on this tripod, which is our bones here. So can you see that? The two ischial tuberosities and our coccyx. And those are definitely 3 places where you can have pain generation. So at our ischial tuberosity is where our hamstrings attach. And so people with proximal hamstring tendinopathy or ischial bursitis, so there's a bursa that sits on top of them, but they often go hand in hand unless they've got true inflammatory issues. And also coccydynia, so people who have pain at their coccyx. They will all complain of pain sitting down. But luckily, they're quite in separate locations. So, you know, all it takes is, well, is it in the midline where your coccyx is, or is it, you know, right at the bottom of your bottom, and you can poke it. All of these are pokeable. And so, you know, you've got your history, and then you can ask them exactly where it hurts. In fact, most of the things in the glutes, you can generally, they'll tell you where it hurts. And you can say, put one finger where you think your pain is at its worst. And sometimes, and I'll say, if you don't know, it doesn't matter. But if you can give it a go, why don't you show me? And that's really handy, because if they're pointing more around the ASIS, you're thinking, well, it's probably more likely to be something like TFL. Where if they're pointing around the SIJ, similarly, if they're pointing just right at the glute, not so helpful, because you've got 3 glutes, 4 deep posterior hip muscles, sciatic nerve, a whole bunch of other nerves and vessels. But nevertheless, then you can do other things to see what the hip range of movement is like, and you can see if you can change their pain. And I expect Emer will talk about that next week, because it's the power of trying to understand what something is, trying to make a diagnosis, coming up with something that makes sense because of the history and because of you've examined it, and then something that doctors can't do so much, and something that physios and soft tissue therapists can do, which is you can try something to see if it makes their pain better. And that also tells you things related to the diagnosis. Because so for example, if I've got someone who's come in and says they have radicular pain, so sorry, they won't say that. They might say they have sciatic pain, so pain in their bum and going down their leg. And I'm thinking, right, this could be from their back, or it could be coming from their bum. So it could be piriformis type sciatic nerve entrapment or irritation. And so one of the ways that you might try to establish which it is, because the tests are often very similar, would be to have a look at their hip range of movement. And if on the side where they have their leg pain, they also have restricted hip range of movement into external rotation, and when you do external rotation, for example, they get their sciatic type symptoms, or they say that when they put their foot over their opposite knee, so sitting a bit like a tailor would, they say, oh, that brings on my symptoms. You start thinking, okay, so it could actually be sciatic nerve entrapment around the deep gluteal space, so essentially a piriformis syndrome. And so then I will say to Emer, because the way the MOD works, we work in a clinic together at the same time. I'll say, Emer, maybe you would be able to try to see if you can change this pain. And Emer will then do some soft tissue therapy immediately in clinic. And if the pain changes, we can be more reasonably sure that it's actually coming from outside the back. Whereas if nothing changes, we say, okay, so it may well be coming from the back, in fact, instead. At which point then we can put our diagnostics down that line, rather than perhaps saying, well, in fact, you probably just need rehab. You need flexibility, mobility work, strength work, maybe some techniques to do self-release, maybe some hands-on as well. I've forgotten what the original question was. But yes, there's great ways of working out by using manual therapy to decide which diagnosis it could be.
Definitely. I think that's a wonderful question you mentioned of just ask. And I think sometimes it's forgotten. We try and perform tests on the clients or patients to provoke pain, rather than just saying, what is it during the week or during the day that you feel this pain? Getting out your car, getting in your car, crossing your legs, sitting, like you said, like a tailor or something, if they do that. Just asking them. It's the old thing, isn't it? And we've had it hard time and time again on here. If you ask enough questions, then they'll tell you kind of what's wrong with them. You know, and if you keep asking questions, then they'll tell you how to fix them, sort of thing. But a lot of the time the trouble, and a lot of this audience are sports therapists, sports massage therapists. And unfortunately, I'm not sure what it's like in physios and allied health professionals, but it is all taught like a list, a book, do this test, then do this test. If it's positive, then it's that. And it's not still not taught enough in that personal way of, so what causes pain? What hurts during the day? People forget.
When I was so before being a consultant in sports medicine, I was a trained GP. So when I was doing my GP training, we had to trial this technique where, there's a study that showed on average GPs will cut in and stop the patient talking after about 9 seconds or something like that when they come in with a problem. And so my GP trainer was saying, so when they come in, ask them to sit down and ask them what their problem is, and then just try to not talk and see what happens. And so what you're supposed to do is mirror a little bit of what the patient's doing. So if they're crossing their legs, you might like to cross your legs, or if they've got their hands in their lap, you can put your hands in your lap, and you just have good eye contact, and you might just look like you're listening. And the idea was that you try to not talk and allow them to talk. And of course, it's a little bit uncomfortable, people not talking, and so generally people will fill the space. And it often meant that the person got round to actually telling you what they were actually there for, as opposed to a slight preamble where they might mention their sore throat, for example, and then not get onto the fact that they have crushing central chest pain. But if you'd stopped them too early, unfortunately, they then mention that about 10 seconds before they're about to leave the clinic, and then suddenly your whole clinic's a disaster. So, but it was really interesting, and so I try not to jump in now, even though I realise I'm sitting there listening to them thinking, oh gosh, I've got 1,000 questions now because they've said that and I need to ask them this. But I will try, absolutely try not to jump in until they've sort of reached a natural conclusion. It's just something to try.
Oh, definitely. Yeah, hugely important.
I don't know if you've experienced a similar, yeah. Oh,
no, without doubt. And I've heard, speaking with GPs, that, yeah, I think the last time I heard it was called kind of empathy training, but it's a wonderful way of showing empathy and improving that therapeutic alliance if you do sit back and let them talk and don't keep, because it shows, and just summing up what they've just said, and more, all the kind of tricks of just showing understanding. And a shout out to, I'm not sure if you're aware of Dr. Gary Mendoza, who's been on the show before. He's got Stages of Change.
So, yeah.
Have you heard him? Yeah, he's been on the show before.
Some of the, yeah.
Lovely. We had him at Therapy Expo, and I'm doing his course actually in February, just motivational interviewing, behavior change, and it's all that. And sometimes it's like, I've noticed myself, and my brother does it especially, but like when he's talking to people, he'll do that, and literally that is to stop himself from butting in and saying something. He'll go, and he'll keep his finger against his mouth, and I realize it's because it's his way of making sure that he doesn't jump in straight away, just to remind him, seal off that.
Yeah.
It's quite a nice technique.
I have to say, there's also the other side of that where, so I will give them their space to tell their story, which is really important. But then when I get onto the bit where I want to clarify bits of their story, one of the key things that I insist upon is that people are specific. So if I say, if they'll say, I've had this buttock pain and I've had it quite a while now, and when I get around to it, I'll say, so what is quite a while? And they'll go, probably a few months maybe. And I'll say, no, when did it actually start? And then we work out they've had it for 1.5 years. And then I'll say, well, and how did it actually start? And if it's a traumatic thing in particular, I want to know the exact mechanism. So I'm not going to go into that now necessarily, but my point is that I try, and it's I'm using words that I don't, it's just a way of expressing myself. So I try not to let the patient get away with anything. So I don't want them to be vague. I want them to be accurate in what they say. And because it's really important for me to understand what their history is. And so I do spend a long time on history, and I want to know how they fell, which bit they landed on, could they get up straight away, did something swell, did they have any pins and needles or numbness, did they go to hospital, did they get it x-rayed, how long they couldn't walk normally for, all these things, so that I get I see in my head, I can image what actually happened. Because if you can get that right, suddenly it all becomes much, much more clear what the problem could be and how you can help them. So it's allowing time for them to tell their story, and then you need to turn their story into something that you can understand. And that's a skill that probably takes years to develop, because you have to also understand what they're telling you and what it means when they're telling you. But if you don't do it, you never move to the next stage, which is that you understand, you see patterns and you learn.
That's great. Great advice. I just realized people listen to the podcast. You couldn't see what I was doing. I was actually putting my finger over my mouth. That's what I was doing then. It just people listen to the podcast going, what was he doing? What was he doing? If we have said anything in this which you're not sure, just go along to YouTube and watch the video and you'll see what we're doing. But we try and keep it. I try and remember that there's people listening as well. Okay. So, you've mentioned Piriformis. You've mentioned sciatica. What about, what else? What else do we consider? What are some of the other things which therapists should be aware of? You've mentioned the anatomy. So
yes. So, well, let's start. The sort of simple things. So let's start with proximal hamstring tendinopathy will get you that lower buttock pain, and it will give you that pain on sitting. But the things from the history will be, so people will have proximal hamstring tendinopathy from things, for example, like doing lots of uphill running or increasing their running load. Equally, it could be because of an acute injury. And the way to injure your proximal hamstrings is to, quite specifically, to go into a kind of lunge position with your front leg, but also at the same time bend your back forwards. So your hamstring, so your hip goes into flexion, if that makes sense. So that's let's say your right leg goes forward. Let's say you skidded on something. And then at the same time, your back folded forward. And that puts that hamstring that's attached to your ischium under stress. And that can cause an acute overload of your hamstring tendon. Equally, if you do that again and again, a little bit by not quite controlling your pelvis as you're, for example, running uphill, and you keep lifting your hip into flexion, and at the same time you're not controlling what's happening at your pelvis, that could give you a more chronic overload of your proximal hamstring. And the symptoms of that are often, pain on sitting. They'll often sit off to one side because they don't want to sit on their bum. And it can also give you discomfort related to the nerves that pass by. So you've got your posterior cutaneous nerve of the thigh, which is a sensory nerve to the back of your thigh. So it could give you pins and needles or numbness or pain there. And you've also got your sciatic nerve, just passing about 2 centimeters or just next to your, it's coming down, it's passing just here. In fact, hang on a minute, just here, like that. And so it's really close to where the hamstrings attach. And so that can just get annoyed because it's next to the thing that's annoyed. Yeah. And that's just because when something is overloaded, you will also get cytokines and prostaglandins and chemical irritation related to that hamstring overload, and that will annoy the nerve that's just next door. And then it could also give you sciatic type symptoms.
Good point. So case history is so important.
Hamstring tendinopathy.
Mm-hmm.
Yeah. Then thinking about, or what else could it be? So glute med and min overload tends to give you more kind of lateral hip pain. So we're talking about pain that radiates down to the, so if that's there, and you've got your hip socket like that, and your glute min and med are attached to the greater trochanter. So that's the socket. They're attached to that knobbly bit that sticks out just like that above your, on your femur. And they're in charge of called the hip internal and external rotation and abduction. And one of the main reasons why people can get an overload of their glute med and glute min is particularly because as we get older, or if we get deconditioned, our muscles aren't as strong. And if you've got your femur sitting in here like that, and on every step you let your pelvis drop because your muscles are not controlling that pelvic from dropping, then what's happening is that the muscles are not only trying to work, but they're also being stretched and they're also being compressed because of the way they're attached. And they don't like compression and they don't like being stretched and loaded at the same time. So you're going to get overload of the gluteal tendons as they're attaching there, which will give you a gluteal tendinopathy. And of course, they will complain about pain at night when they lie on their side, because the tendons which attach to that little that bony bump on the femur that's sticking out will give you pain.
I want to check, because you mentioned two areas now.
Always weak glutes.
Well, let's bring up a question. Becky's in the house. Let's see. Becky says, cause is always weak glutes. No, weak glutes, no, said with sarcasm. I find it astonishing how many gluteal pain sufferers believe their pain is due to weak glutes. How often is this likely to be the case?
That's a brilliant question, because, and I often talk to my patients in clinic and say, doctors and physios love to tell people their bum muscles are weak, that you've got weak glutes. And very often it's not because they have weak glutes. It could be because their glutes are not activating. It could genuinely be because their glutes are weak, or it could be that they're just weak for the job that you're asking them to do. So they could be quite strong, but it's just that you've decided to do something that's really very high impact, and so therefore you've overloaded them. Equally, I also work in an NHS ultrasound clinic, and there are definitely people who have weak glutes. And that's because maybe they're a bit older, they've been very inactive, or, for example, they've had a total hip replacement and didn't do their strength work afterwards, perhaps not because of their fault, but perhaps they weren't given the right things to do in the right way at the right time, or they just didn't know what to do. There's certainly never any blame attached to these things, because people end up in situations for, no fault of their own. But you're absolutely right. We shouldn't blame our patients for not having the strength to do the things that they've done, which has resulted in them having pain. It's not like they wanted to have pain, and potentially they were being enthusiastic and decided they wanted to start running. It's just relative to the thing that they've chosen to do, they perhaps don't have the strength, which has caused the tendon overload, which has therefore resulted in pain. So yes.
Great point, Becky.
I believe in trying not to tell people off for having, a muscle that perhaps isn't working optimally. And it's about then, but I do believe in trying to say, well, can you see that this muscle isn't working perhaps as well? And Emer and I in clinic will try to demonstrate what's going on. And I have to say that one of the other things in clinic that is quite powerful is that one of us is assessing and the other one of us is typing. And so the person who is assessing will say what they see. So I will go, okay, neutral limb alignment. They've got equal quads. Turn around. Okay, the left hamstring is down. The calves are equal. Okay, put my hands on your bum muscles. Squeeze your bum cheek. Okay, the left glute is down. And then I'll go, okay, and now your iliac crests are not level. And so as I'm saying it, the people are going, oh, my glutes are down on that side, because it's been noticed. And similarly, when I'm doing hip range of movement, I'm calling out the numbers. And so patients will see the process of examination, and they will see the way that it's registered and that it's relevant, and how that feeds into the diagnosis at the end. And I try to then summarize it at the end, saying, well, you saw that we saw that, and we saw that your glutes were less bulky than the other side. It hangs together with the symptoms you're having. It stands to reason that regardless of whether we do surgery, whether we do an injection, whether we do rehab, whatever we're doing, regardless, it would be of benefit to get stronger. And that helps them to buy into the hopefully buy into the process of doing some strength work and wanting to be more active. And because unfortunately, at the end of the day, most treatments that are going to be longer lasting to allow people to get back to activity will involve movement. That doesn't mean that, because I absolutely believe that laying hands on people and allowing them to move in a way that's less painful, that perhaps doesn't involve their doctor giving them medication, is very important as well. Whereas I know that there are others who perhaps are not keen on letting patients get away with passive therapies. It's not bad to make someone feel good, to release tissues that then are more comfortable to move. I'm preaching to the converted anyway, so I don't know
No, it's a great point to make.
The point is worth making.
No, definitely.
Yeah.
I remember Paul Coker, who you might be familiar with down in Cornwall, at my Run Chat Live conference, he did a presentation on passive modalities, and he was conscious that a lot of the other speakers there were this was like 2019, were kind of saying, oh, this doesn't do anything and this isn't evidence-based. And his first opening statement is, why is it we really don't like to do things to people which makes them hurt less? What is it about that we always got to say you mustn't do that when they're saying, well, that feels lovely. No, don't do that. This hasn't got any evidence. So no, there's so much truth in what you said. It's weird, isn't it? I think it's where academia maybe kind of takes over and we forget about the patient's experience. You mentioned strength work. This is really interesting because I know, again, one of the kind of weaknesses in a lot of the syllabi which are taught to sports massage therapists, sports therapists, not so much graduates, but definitely leading up to university, is the absence of strength work. And there's still a lot of impetus put on stretching, everything's stretching, normally because something feels tight or pain is confused with, oh, it must be tight. And also that kind of pareidolia thing where you imagine you touch something, you think, oh yeah, this definitely feels tight. The therapist is all part of the kind of like image as well. But you've mentioned a couple of situations where I'm keen to hear about where stretching could be an issue. It could make it worse. For example, with the greater trochanter pain syndrome and also with the proximal hamstring tendinopathy. Is it something where stretching should be taken away or reduced, or do we kind of overplay that?
Yes, I'm not desperately keen on stretching for tendinopathies, partly because they're already a bit cross because they're being potentially stretched and overloaded when you, let's say, do the thing that brings on the pain in the first place. I prefer release of the muscle because you can target the muscle with manual therapy or, for example, a foam roller or some kind of tennis ball or something without touching the tendon. Generally, tendons hurt if you poke them, particularly if they're overloaded. So, you'd never tell people to foam roller their Achilles tendinopathy. You might get them to foam roller their calf. And so I think it's, given that in my head, you can get the same result from releasing the muscle without stretching, I wouldn't stretch something that was necessarily injured. I would prefer to release the muscle and then move that particular body part, move that joint to encourage functional movement. That's where I'm coming from. If people love stretching, fantastic. However, there are some things that I definitely wouldn't stretch, and so I try to tell people who are hypermobile not to stretch. Obviously, and I know this came up last week, and that's one of the things they often really enjoy doing because it's the thing that they're good at. But stretching things that are already stretched or stretchy isn't necessarily good. And what they're doing is stretching the ligaments that are already stretchy. If they actually want to release the muscles, again, it should be foam rollers. But again, those muscles are the only thing hanging onto that joint. And so we should be encouraging in people that have high mobility levels is encouraging functional movements around joints. So improving low-level strength and control so that they get better proprioception, better ability to manage loads when they're doing whatever activity they're doing. But there are some people who are extremely tight who probably would benefit from greater flexibility. Yes, there probably is a place. So in the work that we do in the MOD, I'm very keen on flow yoga type workouts, which rather than holding things at end range for a long period of time, it's more moving through postures. So yes, a flexibility kind of movement. In fact, we've called it the warrior workout to sort of move a little bit
get the
away
guys in.
Yoga, which exactly, a little get them on board with the movement patterning. So it's movement near end, into end range and back out of it, fluid movements rather than just going somewhere and doing static stretching.
Definitely, yeah. I'm totally on board with that. I've always said that a lot of the benefits of yoga is moving from one position to another. It's not necessary. And a lot of yoga teachers I talk to will say, yeah, that's the whole point of it. How long you stay in a pose is something else, because maybe you're improving that stability and that, but it's the moving and the flow into the next position. And that makes sense, because that's what we do in life, isn't it? It's moving from one position to another and getting variability. So it's nice to hear you say that, kind of a vinyasa thing, isn't it? Isn't that the flowing movement one? And as opposed to just stretching for the sake of it. Gosh, well, look, it's 9:04 already. That went very quickly, too quickly, as always. But I'm very excited to hear that. Are you going to be able to come back next week?
Yeah,
are you gonna?
Sure.
Yeah, that'd be amazing.
Come back, I think. Yeah.
And then Emer's going to be in the corner typing. Is she? You're going to say things, and Emer's going to be typing what you say down.
Absolutely not.
No.
Emer's great. She's gonna. And Alex has asked a question about week.
Oh, let's bring it up.
Alex, you should come back next week, because I think Emer will be able to cover that easily in her. How to change things, basically.
Oh, cliffhanger for next week, Alex. There you go. You're going to have to come back. Alex asked, going back to the weak glutes point, how do we test to see if glutes are weak? How do we test to show that their strength has improved? Yeah, we'll leave that for next week if that's okay, Alex. And also the other thing which I'll be asking next week is, how do we know that that muscle is showing reduced strength, because that's part of the pain experience they're going through, and it needs to be. That's not the cause of the pain. Maybe that's just one of the symptoms of, it could be that as well. The part of recovery is not using it. So it's a tricky one, but what a great cliffhanger. What a great pathway to next week. So, thanks, Alex. I hope you are able to make it back. If not, let me know and I'll make sure you get a link to the recording. But we are back next week. So I'm really looking forward to that. Dr. Sarah Rollins will be back with colleague. This is colleague then in the Ministry of Defence, yeah? Or is it pure as well?
No, so Emer Acton is a clinical specialist physio, and she works in the Ministry of Defence. However, she is just about to move to a very fancy pastures new at McLaren to work in F1, and I'm devastated, but she deserves it, because she's brilliant. But yes, and you can ask her about that next week. Yeah,
I've been given privy to some of that. It'll be very exciting. We'll make sure that all goes into the write-up. So so yes, people, thank you very much for joining us. I'm going to have to let Sarah Rollins go now. I'm sure you've got other things you need to be doing. But join us next week. If you listen to the podcast and you think, I want to get in there and ask these people questions directly, then all you got to do is go along to the Sports Therapy Association YouTube channel. And a couple of days before, the advert for the episode will appear, and you can click on the remind button and they'll send you out a reminder when we're about to go live. Otherwise, just follow us on social media, either UK_STA or Sports Therapy Association on Facebook, or follow me, Run Chat Live, anywhere. And I put out loads and loads of adverts to let people know what's coming up. Thanks, people, again for joining us in the live lounge. Gary Benson, founder of the STA, says, thank you, Sarah, for sharing your extensive knowledge. In my army days in Aldershot, I don't think we were as well looked after. No, Gary, I'm sure you have to make sure you're here next week, Gary. We can swap some stories. I was expecting you to come up with a few army stories, and the whole of your family, all your mini Garys. Nikki Mansfield says, great stuff. Thanks, Sarah and Matt. Thanks as always. Gary comes back. Great episode, Sarah and Matt. So part 2 next week, where we look at some of the practical of what to do if we've decided these people are suffering from different conditions. So Sarah, don't go yet. I'm just going to shut down the lounge and I'll say goodbye to you quickly. Thanks everyone for joining us, and hopefully we'll see some of you next week. Take care.
You're listening to the Sports Therapy Association podcast, putting evidence back into soft tissue therapy.